Okay, let's move on to our next case. And again, we're going to try to be moving up towards this concept of the working into the mCRPC space. Again, working from the asymptomatic to minimally symptomatic patient, and then obviously we'll work into the really progressive disease. So this next case is a 59-year-old African-American male who presents in July of 2013 with lower urinary tract symptoms, PSA of 28, AUA score of 24. Has no allergies. He's currently on some finasteride as well as an alpha blocker of terazosin. Also on a little bit of metformin and lisinopril. He's never had a surgical, he has no surgical history, does have a family history of prostate cancer, and has 3+ prostate on exam. He gets referred to urology, has a 43-gram prostate on ultrasound. Biopsy shows Gleason 10 of 14 cores, Gleason 4+5. He gets a staging workup, and on CT scan, he has bilateral iliac adenopathy, obturator adenopathy to the right, lesions to the pelvis, sacrum, and coccyx that are blastic. Bone scan shows L4-5 involvement. He gets started on complete androgen blockade, and this was in 2013, so obviously now if this gentleman presented, he would obviously be placed on docetaxel chemotherapy concomitantly. In September of 2013, his PSA is again checked at 0.85. He has an alkaline phosphatase of 236. His calcium is 9.7. In September of 2013, based upon his bone scan involvement, he's also started on denosumab, 120 milligrams subcutaneously monthly for SRE prevention. And then in follow-up laboratory values in October of 2013, he has a rising PSA of 1.32, testosterone level less than 10. So let's stop it right there. So now we have a gentleman, again, who has nodal disease, has been started on complete androgen blockade, has been started on, appropriately so, on bone targeting therapy. And that's sort of, I think, what gets lost amongst the urology world is the really lack of use of bone targeting therapy in patients with metastatic bony disease. Wouldn't you say, Joe?
Yes.
So, so here he has a PSA of 1.32 despite having a testosterone level of less than 10. We know he has bony involvement. We know he has iliac node involvement on CT scanning. So this, and he's ECOG 0. Chris?
Well, his PSA is really 56. He was on finasteride, so we knew he was. His numbers are not good. You're saying though that the bone scan really didn't correlate with his CT scan. So is that correct? So.
Right. There seemed to be some question whether or not they thought that the bone scan had L4-5 involvement, but on CT, they clearly identified these blastic lesions to the pelvis sacrum. Does that change your management at all?
Well, I think the CT scan is probably more informative in that case, but it's certainly right. Denosumab would be, if he had clear-cut disease to bone. That's why I wanted to clarify, and it sounds like he probably did, based on the imaging, to start denosumab having metastatic, known metastatic disease. And now he's gotten his Sipuleucel T.
Well, there's the question. So now he has received no therapy. So what are his options based upon AUA guidelines? He's ECOG, so he's a very functioning individual, has bone and soft tissue, but he clearly has CRP. He has CRP. He has M1 CRPC.
Well, this is probably the biggest net of options for him in the minimally or asymptomatic category with metastases. So this would be a good place to position Sipuleucel T before some of the other treatments, but his other options would also be Abby with prednisone, now with Prevail and enzalutamide, docetaxel, although since he's not that symptomatic, but if he has the adenopathy, using RAD223 wouldn't be indicated because he's not symptomatic bone mets, although you can have up to 3 centimeters of lymph node involvement to treat that, but he doesn't quite qualify in the other criteria.
Do you have strict definitions that you personally use in terms of, quote, pain symptomatic? What is minimally symptomatic? Do you have strict definitions? in
Well,
terms
that is, I think, a little bit less well defined. It's a little more open to the clinician's interpretation. Oftentimes, half of patients who are being treated for pain are actually on non-steroidals. They aren't on opioids initially, and about half are on opioids. And I think that's probably a relative difference. And if you take the ones that are on non-steroidal, they really are in your minimally symptomatic, right? And I don't know if my medical oncology colleagues would say once you're on opioids, you're clearly symptomatic. They may be a differentiator, but the ones on non-steroidals would fall in the minimally symptomatic in my book.
Yeah, I mean, I think the use of opioids or not is frequently the cutoff. You know, I mean, in the clinical trials, of course, there's different definitions for symptoms based on what kind of analgesics you're using, but I think in general for us, opioids equals more symptomatic.
Dan, would you?
I would agree totally with that.
Okay. So from an NCCN standpoint, so here's a gentleman who's minimally symptomatic. Let's say he's not taking opioids. His PSA is rising. We know he has a castration level of testosterone. Mm-hmm. What's the current NCCN tells us what at this point?
Well, they're saying that in a good performance status patient that has more than 6 months to live, a Sifulus LT would be a very appropriate thing to get in early. And again, this was discussed earlier, but you know, if you have a patient with a low PSA and low volume disease, that seems to be the patient that's going to benefit the most from early immunotherapy.
And Joe, you had mentioned this before. You had mentioned the Paul Schellhammer's work on the quartile data. Can you run through that for us real quick again in terms of looking at quartile data in the post-analysis of the IMPACT trial?
Yeah, when they looked at the quartile data based on PSA stratification, the one that stands out is PSAs under 22. Patients actually conferred a survival advantage of about 13 months. And so our goal is to try to treat people earlier when their PSA has not exceeded that 22 range.
Do we know if the other companies are going to look at PSA data, like in terms of looking at patients who are on Cougar or Affirm or Prevail? Are they going to ever look at that PSA data? Do you have any idea?
know.
Dan?
I know that they recently published data on radiographic progression-free survival, but but nothing on PSA as far as I can recall. I mean, we looked at the PSA data in SWOG 9916, and we also looked at that in TAX 327, and we found that a 30% PSA decline seemed to correlate best with survival. But I think no other trials have really looked at that carefully.
Or like, because what you're talking about in Paul Schellhammer's paper is looking at the absolute PSA, not necessarily a decline,
post-treatment
since we don't necessarily expect a decline after
Right.
CYP anyway.
Right. So appropriately so, this gentleman did receive 3 cycles of CYP from November 14 through December of 2013. As expected, as Dr. Hagano pointed out, the PSA, as we know, doesn't necessarily go down with CYP. PSA was 1.85, alkaline phosphatase 202. In June of 2014, patient is still doing quite well in terms of functioning, but he does now start to have a rise in his alk phos to 258, and he has some new back pain, primarily to the right SI joint, requiring some non-steroidals as well as some occasional opiates. They go ahead and restage him, and they get a sodium fluoride PET CT, which is being shown. And what he's got some new lesions basically now present through the sacrum, as well as throughout the entire, or through the SI joint. So now we've got a patient who is now progressing past CYP-T. Now he is symptomatic. He is on opiates. He's got bone scan involvement. He's got worsening bone scans, and let's just say on his sodium fluoride PET that he's got some limited adenopathy, maybe less than 2 centimeters, but no visceral mets. So he's received CYP-T. His PSA is rising. His alkaline phosphatase is rising. He's got new lesions on bone scan. He's taking some opiates. What are our options at this point?
I think that at this point he has the option of considering Xofigo. he could be treated with enzalutamide or Zytiga and prednisone. Given that he's symptomatic and it's mostly bone disease, I think he has an advantage of getting some pain relief with radium-223 and also an overall survival advantage there as well.
Dan, Tia, you all have been both big proponents of Xofigo radium-223.
Yeah, I mean, this is one of those situations where we're still learning about how to optimally cycle these effective agents. And I think any of those choices would be fine right now.
Great. I agree. I mean, the problem is we have no way to distinguish one versus the other. And it's a matter of individual preference.